year-old male from Australia presented with faintishness for 1 day duration. And he was suddenly developed faintishness for around 4 months back. And it was associated with palpitation and shortness of breath. And admitted and also associated with older bowel habits, intermittent diarrhea and constipation 10 months ago. And he was diarrhea, mucoid diarrhea, mucoid, he had melena also. And also he had rectal bleeding, blood streaks on stool, tenesmus present, has incomplete defecation, sense of incomplete defecation and failure to express. And he has no history of vomiting and loss of appetite, but has significant loss of weight. He has abdominal pain, which was on joint region, and it was colic type pain associated with abdominal distension. He has no history of inflammatory bowel disease, and no fever, no main joint pain, no oral ulcers, no history of outside food consumption, and he has past history of amoebiasis around 20 years back, and it was completely treated. And after this episode, he was admitted to Homagama. Blood transfusion was done 2 episodes, and colonoscopy was done. It was failed due to obstruction. And then he was transferred here, and CT was done, colonoscopy was also done here, and biopsy reports came as tubular adenoma with low-grade dysplasia, and tubular villus adenoma with tubular adenoma. And he has no history of recurrent UTI, and no urinary symptoms, and no icterus, no any backache, no headache, no hemoptysis chronic cough. And in his past medical history, there was no any bleeding disorders, no hypertension, diabetes, and he had lipoma. He had underwent lipoma extraction 15 years back, and allergic history from there's no any allergies, and family in his family history, he had family history of endometrial carcinoma and prostate carcinoma, second degree, and no history of inflammatory bowel disease, no history of colonic carcinoma. He is a teacher, unmarried, and financially stable, not smoking or consuming alcohol, and he has insight about his disease and dietary habits. On examination,
what are your differential diagnosis? preservatives that alcohol itself contains. Sodium citrate. What is shelf life of a blood bank? If your household is going to be blood transfusion location, what things will you check? Is that one form, DD form? Form is the one filled and sent to the report. Okay, you check patient's group with whatever the form it is matching. Okay. So you check the group whether it is matching. Okay, so you make all the recorders to confirm whether it is matching. Anything else we can check? Okay, right. Now we got any of this patient hasn't got hemoptysis. Why did you ask that question? Passing from there. What is the common site of metastasis in urological cancers? Commonly going to the lung? Colonic cancers? Okay. Then you ask about family history of colon cancers. What do you know about family history and colon cancers? Can you give some examples? Familial adenomatous polyposis, right? Yes. What is the mode of inheritance? So if a family member has got that, what is the chance that his sibling or his children having the disease? If one has got FAP, but the chance it's all the children with the disease. Any other familial diseases causing our cancers? Is it common? Do you think this patient has got FAP? And this patient has got FAP. Why? What's the reason? Couple of reasons. Okay, because family has got endometrial CA, this cannot be a FAP. Is that what you have done? Any other reason why this cannot be a FAP? So, you get FAP only if you have relations. What is FAP or not? Can you get FAP without the relations getting the disease? Hello, sir. Yes, one of the
presentation time company presentation 40-30 one is
He's not able to do his cardiologist. He's a cardiologist. Palpitation to indicate that not the palpitation. Okay. So, Chandra is very good, sir. Mama, I will contact you. Right, okay. Right, go ahead with your examination.
He was and raised BMI was 18.56 kilogram per square and pale and no interview, and there was no any kind no virtual and no plugging and no evidence of damage like pedicure and no physical stigma of inflammatory bowel disease. And on abdominal examination, abdomen was soft and non-tender, no masses, no hepatomegaly, bowel sounds were reduced. And on digital rectal examination, no skin tags in visible lungs, no ulceration, no no fissures, and sphincter was increased. But he did not complete the examination because of the pain. Pulse rate was 72 and respiratory system there was no
That's all. So your time up, 20 minutes gone. So long case is for 20 minutes. 10 minutes with one examiner, 10 minutes with the other examiner. Sometimes present the history like how you live. And then the way it moves off, and then the other things that will take on, right? From there. So, when did we pass this presentation? Everybody heard what was told, what was discussed? Huh? So I won't pass. Huh? So my mark would be around 35, right? For this type of presentation. Do you think you have been enough marks? No. So, right. So what are the other thing you have mentioned is lipoma extraction has been done. There's nothing for lipoma extraction like juice extraction. The excision of lipoma, right? So this is how I just want to present because this is how long it goes in the exam, right? So you need to practice presentation, right? Then let's discuss the subject matter now. Until treatment of simple things, amoebiasis, right? Blood transfusions. What are the now there were a couple of students who came late, 1 week who are they? Only you or somebody else? No. Right. So you have informed Deepak and that sort of, right? Yeah. What are the preservatives in RCC? Red and concentrates. Sodium citrate and your red cells, and sodium citrate is like this. You have several times go to sodium citrate. What else? What are the RCCs, preservatives? Mannitol. Mannitol is blood packing. Hands up anyone who can give. There are 4 preservatives.
Result is done.
Yes. I have texted you something that's no point. Right. Anyone? Yes? Huh? Say right, I need 20 talk. I'm not sure that, but I told you about it. Either there's nothing like that. Many talks now. Hematology, how do you name? How come? So that itself I will fail. Can you give a product to a patient when you don't know what is in what is in the pack? Yes, CBD, citrate, phosphate, extrusion, A. And you have to know why these are there. Why citrate is there? Angular. Why phosphate? Can you find out, please, why these components are? Alright, second MBA, second MBA, you have a PET cycle. Have you learned those things? Right. So find out why these are there. Okay. Right. Now, how would you investigate this patient? If this patient comes to you with this history, right? How would you investigate this particular patient to find out what's the cause? Yeah. Okay. Yes. So how would you confirm your diagnosis? Now, differential diagnosis, you said colonic cancer, amoebiasis, IBD. The similar type of presentations cannot, because the patient has got sensation of incomplete evacuation, bleeding PR, mucus. So, other than these differential diagnosis, anything else can you mention? Anything come? Okay, rectal CA. Huh? Diverticulosis can be, but usually they don't have erythemas, mucus, very unlikely. Right? They can have bleeding, they can have pain, they can have change of bowel habits, right? What is diverticulosis? What do you understand by diverticulosis?
When the patients have diverticuli in the intestine, they are getting infected by
What type of diverticuli are in the large bowel? What are the types of diverticuli you know? In the gastrointestinal tract? Huh?
in large ones.
So in the entire gastrointestinal tract, can you help me classification of diverticuli? Anyone can raise your hands? Anyone can do it? Yeah? Huh? True and false diverticuli. So, what is true diverticuli?
The diverticuli is formed with the outpouching of the
Wall thickness.
thickness of the wall.
Yeah, so true diverticuli has all four layers of the bowel or the gastrointestinal tract.
First diverticuli.
Pharyngeal pouch.
Is a diverticuli. Right. Okay, but small bowel diverticuli? Hello. Hello. Morning. Alian. You come around 9.5. Yeah. So diverticulate? Why you got false diverticulate?
It's just the mucosa and the mucosa is.
Just the mucosa bulges out, right? So, in which part of the bowel, large bowel, where you don't get diverticulosis? Is which part of the large bowel you don't get diverticulosis? Is there anything like that?
Cecum.
Huh?
Cecum.
Cecum. Cecum you don't get diverticulosis. Rectum. Why rectum you don't get diverticulosis? Huh? Yeah. Because
This is more distended. More
it
distended.
expands. Not because it expands. Yeah.
This is a retrograde.
Not because of it's a retrograde. Ascending colon is also retrograde. Ascending colon. Huh? Not because of this.
So tinea coli. Yes. Entire muscle.
Entire
Muscle.
rectum is covering with the muscle, whereas in the large, the colon,
Tinea
it
coli.
is concentrated in
Tinea.
certain areas. Isn't it?
Tinea coli.
So, because of the tinea is no more there in the rectum. Therefore, rectum won't get diverticulosis, right? So, if I say diverticulosis of the rectum, what is the commonest part of the bowel, large bowel where you get diverticulosis? 6.2, right? What are the complications of diverticulosis of the colon? Complications of diverticulosis. They can be, yes. Huh? Perforation. Huh? Not here. It can be a can be a site for bowel obstruction. How a diverticulosis is caused bowel obstruction? I agree. It can cause obstruction of the bowel, but how can it cause? It acts like a band. How can diverticulosis cause obstruction? Miss? Anyone? Right. How can diverticulosis cause obstruction? It can cause abscess formation. That's another complication. Anyone? Any idea how diverticulosis cause obstruction? What is other complication other than you mentioned bleeding? You mentioned abscess formation, perforation. Any other complication?
Diverticulitis.
Diverticulitis. So, what are the sequelae of acute inflammation?
Separation.
Recurrent acute inflammation. Abscess formation and sometimes recurrent acute inflammation. So those are the sequelae. So how can it cause obstruction?
Fibrosis.
Huh? Yeah, it can cause fibrosis and stricture formation. Then it can cause obstruction. Right? What else? What else? What are other complications? In this abscess, there can be mass formation, right? Then, if this diverticuli forms inflammation and surrounding tissue pumps and adhere to them, they can cause fistulation. So you name any fistula can be caused by divertical disease. It can cause polovesical, it means polovaginal, with the small bowel polo entering, right? Or other part of the polo fistulas or polovesical, or if it comes to the anterior abdominal wall, it can perforate into the abdominal wall and goes through the skin, or we call it polocutaneous fistula. So these are all types of fistula it can cause, right? Right. So that is about divertical disease. Any questions? It is common after the age of 55 years or maybe 50 years, right? Low fiber diet, low residue diet, less water intake are risk factors, right? Okay. Right. So in your presentation you said rectal tone, the anal tone is normal in this patient. Increasing, tone is increasing. Is it important to assess the anal sphincter tone in this type of patient? Why do you want to assess the sphincter tone? Because of the diarrhea. Any other reason why the sphincter tone is important in this patient? Rectal cancers, more metastasis is there. Then there's a local spread.
Local spread.
Then we will call it metastasis. That is not the reason. Why do you think patient has got a rectal cancer? We don't know what this patient has, but the patient has got rectal cancer. Why do you think the sphincter tone assessment is important? Yes. Yeah. Huh? To see whether the patient has a fecal incontinence. So what is the value of that? Fecal incontinence equals sacrum එක spread වෙන්න පුළුවන්. ස්වින්ට් එකෙන් තද කරගෙන ඉන්නවද sacrum එකට යන්න ඕනේ ටියුබ් එක? Because the tumor has gone into the sacral plexus, patient has got incontinence. Okay, accepted. That is possible. What else? Yeah. Yeah, for the management point of view, if you are going to do an anterior resection, then the patient should have good continence. If the patient has got already lax sphincter and incontinence, then no point doing anterior resection in the patient. Because anyway, patient is going to have incontinence. With the interior surgery, the continence may be much less. So if your sphincter tone is low, and if your tumor is also low, you are not going to preserve that anal canal, right? So then, rather than going for anterior resection, it's always discuss with the patient and go for permanent colostomy with abdominal perineal resection. Hello? therefore, assessment of the symptom tone is not should be done during your examination. Right. Now, yeah, how would you investigate this patient? Find out the cause. Okay. Colonoscopies, all of you should have seen, or if you haven't seen, you must see. I'm not going to discuss this. When you go to the endoscopy, you have to know. What are the, if you have to take consent for this patient, colonoscopy, what are the important things you will tell the patient? Because you may not be able to describe because you may not know, but you have to tell the patient that your patient's large bone is going to be seen with the camera. Yes. Like bleeding. Yeah. Perforation. Yes. Large bone can be perforated. Any idea what precipitation have perforations? 5%. 1%. Huh? 0.1%. Right? 1 in 1,000 or 1 in 1,500 perforated can occur. Yes. What else? Okay. Complications with what are other complications that can happen during colonoscopy? Hands up those who haven't seen colonoscopies? Yes? Hands up those who were in the endoscopy yesterday? You have learned what I have asked you to learn? Huh? Okay. There are the others also. Huh? Right. So, yeah. Did you see colonoscopies yesterday? Huh? Huh? What mode of anesthesia we use for colonoscopy? Huh? Huh? Sedatives are used. Okay. What are the drugs we give? Loud. Fentanyl. Is it a sedative? Fentanyl is a sedative. Analgesic. What type of analgesic?
Opioid.
NSAID?
Opioid.
Huh?
Opioid.
Who were there in the endoscopy other than you? Yes? What is fentanyl? Opioid. What else? Other than fentanyl? Huh? No, what are other medications we give? Huh? Propofol is given. How many patients we gave propofol yesterday? Who were there? Yeah. Huh? Loud. Yesterday propofol was not given. So no other days we give propofol. Other days also we don't give propofol for colonoscopies. Not in this country. Not anywhere in the world. Propofol. So what are the medications we give? We give analgesics and fentanyl. Midazolam. So what are the complications we can get? So you have to tell them respiratory depression. So what is the antidote for fentanyl overdose? Naloxone. What is the antidote for midazolam overdose?
Flumethrin.
So you have to make sure those are available in the endoscopy room. When you go next time, please see. Before giving these medicine, you have to make sure the antidotes are available. Right? So those things has to be mentioned to the patient. We are giving some sedatives and painkillers. You might get some complications. complications related to that, but we have facilities to rectify this. Right. Okay, so colonoscopy is done. Colonoscopy shows, let's say, imagine there's a malignant looking growth around 10 centimeters from the anal verge. Let's imagine, for discussion point of view. Then what is the next step? Before staging, when you see a lesion, biopsy. What do you think the biopsy will come as? I forgot to tell you, the other differential diagnosis you haven't mentioned is a solitary rectal ulcer. That mimics malignancy. The only way is histological diagnosis, right? But the treatment is completely different. So, when you take see a lesion, you take a biopsy. What do you think the biopsy will come as? If it is a rectal cancer, what would be the biopsy report? Simple, no? I am not asking difficult questions. Next one. Biopsy will come as?
Adenocarcinoma.
Huh?
Adenocarcinoma.
Yeah, but what type of malignancy is common in the rectal? Adenocarcinoma. Hello? What is carcinoma? What is carcinoma? Malignant lesion is carcinoma. Epithelial malignancy is carcinoma, right? What is sarcoma? Muscle. Can you see those things? Sarcoma, carcinoma, right? So you have to know these things, right? Okay. You have to know. Don't come to exam without knowing those things, right? So it comes as adenocarcinoma of the rectum. Then what is the next step?
Stage.
Yeah. How do you stage? Okay. CT scan of the abdomen. No, you may be correct. You are the house officer, right? Yeah, CT scan of the abdomen. What sort of CT will you do? You don't have to do. Ultrasound scan of the abdomen is done commonly because that is freely available. But actually, now we don't depend on ultrasound scan to get tumor metastasis because we have CT scan. So CT scan of the abdomen is must. What sort of CT we do? 1%. Next is I can't see here. What sort of CT you will request? Your consultant or the senior minister will ask you to get a CT scan done. So what would you write in the request form? What CT scan? Yeah. Contrast enhanced CT scan. What else will you write in the request form? This will be asked in the exam. If you say CT scan, okay, you are the house officer. What will you write in the request form before sending to the radiologist? That's why you are in the wards to see these things. Okay. So everything third year stuff. What are the important things? With regard to the allergic history, yes. What else?
Bronchial asthma.
Huh?
Okay, bronchial
Renal
asthma.
function scale, you know.
Results of the
What renal function?
serum creatinine.
Serum creatinine level.
Bronchial asthma.
Huh?
Bronchial asthma.
Whether the patient has got bronchial asthma or not. So those things has to be written, otherwise the form will be returned to you, right? Okay. So you do a CT scan to assess liver. Then what else? What other staging investigation will you do? Not we can do, I will do.
I will not.
Huh? CEA level, okay. CEA level may be normal, not all colon and rectal cancers will secrete CEA, but you have to do as a baseline for follow-up purposes. It's important.
This is CT. I would like to do the cancer contrast and CT for both abdomen and pelvis, and also chest X-ray.
Okay. When did you start this appointment? When? 23rd of October. So we have operated about 4 rectal cancers since then. Have you seen these patients? So what are the stages of these patients? MRI pelvis, that is the gold standard for local staging of rectal cancers, right? Okay, so MRI pelvis, if you do MRI pelvis, you don't have to do a CT pelvis again, you can just do abdomen CT. If facilities are available, CT chest as well, but otherwise we depend on chest X-ray. So those are, and the CT, so those are the staging investigation for rectal cancers, right? Right. Now, have you seen these patients? Has anyone seen who has got these rectal cancer patients in the ward? You've got. Have you seen these MRI scans? Reports at least have you read these reports? Right. What are the things they mention in this report? Okay, if you haven't seen, please see when they come. And during the ward round, I will be asking, right? So during this session, we will teach you what are the treatment options available for these patients. Right. So staging investigations, then you do routine set of investigations to assess this patient's fitness for surgery. That is same for all major complex surgeries, right? So that you have to know. Right now, how would you treat this patient? This patient has got a tumor at 10 centimeters from the inner verge. Yeah. What are the treatment? What is the length of the rectum? What is the length of the rectum? 15 centimeters, right? So as far as surgery is concerned, rectum is divided into
3 parts. 3.
lower 1/3, upper 1/3 and middle 1/3. This is anterior, this is posterior, this is dentate line, this is the retrosigmoid junction, right? So 5 centimeters, 5 centimeters, 5 centimeters, right? So this patient has got tumor at around 10 centimeters, right? What is the treatment that we do for rectal cancers? Surgery? Anti-rejection. What is anterior section? What do you understand by anterior section of the rectum?
We can go in and
Huh?
reset the tumor and anastomose the two ends.
So anywhere in the tumor, we can go in and resect the tumor and anastomose. If it is in the common bile duct, yes. If it is in the pancreas, yes. If it is in the anywhere, it's done. So what is anterior section? Huh? Huh? Leaving the inner sphincter is anterior section. Okay? Huh? Anterior section of the rectum means removing the rectum. Simple as that. Removing the rectum. Right? So, depending on the type of the part of the rectum we remove, we divide into, for your purposes, 3. High anterior section. If the tumor is in the upper 1/3, we do high anterior section. If it is in the lower 2/3, we do low anterior section. Right? There are other sub-classifications, but at your level, not necessary. Now, if you know high anterior section and low anterior section, that's more than enough. Right? So, what is the requirement? Oncological requirement? What is the distal resection margin you should have? Yeah, 1 centimeter. Let's say 1 centimeter is enough. Right? So, if you can leave, if the tumor is in the lower 1/3, and if you can get 2 centimeters with the tumor, or 1 centimeter with the tumor, with clear margin, that is enough. Why that is important? Because if the tumor is very low, you have to decide whether you are going to save the sphincter or not. If you are going to save the sphincter, then you should be able to take at least 2 centimeters from anorectal junction without the tumor with the specimen, and if there is enough space, you can anastomose. Is that clear to you? Any doubts? Right. Okay. Next question is, now, are we going to operate this patient straight away, or does this patient need any neoadjuvant treatment? How do you decide that? Other thing you have to understand here is, colon cancers are completely different from rectal cancers. Even though they are adenocarcinomas, the management wise, they are different. Why? Rectal cancers, we give, the disease is advanced, we give neoadjuvant treatment, whereas colon cancers, we don't give. Why? We don't give?
By the time it's
Colon, you can't irradiate without irradiating the surrounding vital organs. Therefore, no radiation given for advanced colon cancers, whereas rectal cancers you can localize and irradiate because rectum is a fixed organ and it is in the pelvis, so you give radiotherapy. So neoadjuvant treatment is given. Okay. Now, how do you decide whether this patient needs radiotherapy or neoadjuvant therapy or not? It depends on
stage.
No, nothing to do with the size. Size is not important at all. But whether it is infiltrating the what is known as mesorectum. So what is mesorectum? There is a thing called mesorectum behind the rectum. So behind the rectum,
Circumference.
there's another area called like mesocolon, mesorectum. So this is mesorectum. Right? Whether this tumor has gone, how much it has gone to the mesorectum is important. That is why the investigation to detect that is an MRI scan. So outer lining of the mesorectum is called
Circumference section margin. Circumference section margin.
no, not circumferential resection margin. Outer margin of this mesorectum is called mesorectal fascia. So this is the rectum. This is anterior. This is posterior. Mesorectum is very thin anterior. If you have seen the surgery, laparoscopy when we do anteriorly, the mesorectum is very thin, whereas posteriorly it is thick, right? So this layer is called mesorectal fascia, right? So when the tumor starts here and goes outside, right, then outermost margin of the tumor and distance from outermost margin of the tumor and the mesorectal fascia is determined by the MRI scan. And if that distance is more than 2 or 3 millimeters, then the radiologist will tell us your circumferential resection margin is clear. Right? If the tumor has come up to this level, at least 2-3 millimeters are there, then the radiologist will tell circumferential resection margin is clear. If the circumferential resection margin is clear, then those patients we straight away operate, because this hasn't gone beyond this. So it is in the mesorectum, but just at least, let's say 2 millimeters would take so that you can take the tumor. So for your point of view, what you have to know is not these millimeters. If you say in MRI scan, if the circumferential resection margin is clear, that patient undergoes surgery first rather than undergoing neoadjuvant treatment. That's more than enough. Clear? Okay. Right? When you read this MRI report, there are certain various other things. Extramural vascular invasion, blah blah blah, which you don't have to worry about, because those are post-graduate things, and as you have just now experienced your long case, you may not be able to finish your examination findings with examine. So, no, very rarely you will come to the discussion up to this level, right? So sometimes it's possible. Therefore, you have to know that if the circumferential resection margin is clear, patient will undergo surgery first. If it is threatened or involved, the patient will need neoadjuvant treatment. Okay. So, upper rectal tumors, high anterior resection, middle and lower rectal tumors, low anterior resection. Any questions? You have to clarify questions now, huh? Right. So go home and read and ask if there are any questions during the workshop. Huh? Okay. Now, other question is, who are the patients that we defunction? Some patients we do defunctioning stomas. Some patients we do. Now, what we will do, once we remove the tumor and the rectum, we anastomose the colon into the rectum, the rest of the rectum. That you understand? So, colorectal anastomosis is there. If tumor is very low, sometimes when the 2 centimeter margin is taken, we will anastomose coloanal onto the anus also. Right? Coloanal anastomosis, very low anterior sections. Right? But the integrity of the bowel is maintained with the anastomosis. Right? If you can't take the 2 centimeter margin or 1 centimeter margin without compromising the sphincter, then what is the surgery? Abdominal perineal resection, and the patient will end up with a permanent coloscopy. Clear? Any doubts? So these are the basic concepts, and if you know this, if you get a case, you will pass. Right? Right. So which patients we defunction? Before going into that, so when we maintain with the integrity with the anastomosis, what are the complications these patients can get? Yes, main complication is anastomotic leak, right? So when you are taking consent, might ask you what are the important things you will mention in taking the consent for this surgery from the patient. One is anastomotic leak, right? Some data has shown 20% anastomotic leak rates, right? So 10 to 15% definitely, right? Our series is about 3% or 5%, right? But you have to know that, you have to take the consent. What are the other important things in the consent for anterior section? Okay, patient may need a temporary stoma anterior section, right? So you take consent for stoma. What is it? Let's say, now I told you this is very unlikely to be FAP because FAP presents very early. FAP patients develop polyps during their teenage. So if you don't treat them, they will develop malignancies in their late teens or early 20s. The youngest patient we had was 17 years, right? So therefore, if you get cancers later on, it is not FAP but HNDCC probably or sporadic, right? So then anastomotic leaks. What else? Let's say 35-year-old male comes and you have to do an anterior section. What are the important things in the consent? Well, yeah. Huh? Impotence, yes. Because the hypogastric plexus is just near in the mucorectum. So when you dissect, you may damage the nerve irrigators, right? So you have to take the consent for impotence. If the patient is very young, like what we did for this other patient, you have to do sperm banking prior to surgery, right? So you have to discuss these things with the patient. Then, what are the complications? Main patient's impotence, the anastomotic leaks. What are other important structures which are lying close by? I showed you when you came to theatre the other days. Ureters. So ureters can get injured, right? So uretary injury, there is a possibility. Then, what is the blood supply to this area? Inferior mesenteric artery is a branch of inferior mesenteric artery is a branch of which vessel? Femoral vessel. Whose anatomy would you write? Solardias or anatomy? Inferior mesenteric artery comes from femoral vessel. Next, behind it. Inferior mesenteric artery is a branch of abdominal aorta. Anterior, third anterior branch of the abdominal aorta is inferior mesenteric. So, what is the possible complication? During surgery, massive bleeding cannot, right? So, and also reactionary bleeding is also possible because the stitches might give away. So, hemorrhage. So, those are important complications you have mentioned, right? Okay, so how do you decide whether the patient is defunctioning stoma or not? Yeah. Anastomotic margins are unhealthy. Okay. Comorbidities like not really necessary. Diabetes, vascular disorders like peripheral vascular disease. So what are you trying to tell us? If the blood supply to the anastomosis is not satisfied at the time of surgery, if the surgeon is not happy with the blood supply to the two ends, then the chances of anastomotic lesion is high. Right? Therefore, somebody might decide to defunction. Anything else that is important in anastomotic healing? Yeah? Okay. Tension. Yeah. Tension at the site of the anastomosis. If the anastomosis is under tension, then it might fall apart. Because of two things. One is because of primary tension. More than that, when the tension is there, blood supply is going to be less. Therefore, then surgeon feels that the anastomosis is under tension, he will decide the patient may need. What else? At the time of anastomosis, if there are contamination, cross contamination in this area, then there is a high chance of infection. Because there is always, after surgery, there will be some blood collected in this area, hematoma. So this hematoma can get infected. And then, of course, infection causes less healing, anastomotic healing. What is the other important thing? Wound healing in general pathology. Patient's nutrition. That's why we do albumin levels. So in your examination list, you haven't mentioned about edema of the patient. Did you mention? No, you haven't, right? So when you examine these patients, all major surgeries, other important thing you have to mention in male patients is when you examine, if you suspect that the patient may need major surgery, probably patient may need catheterization also. So therefore, you have to mention whether the patient has got phimosis or not, right? Because otherwise you will detect that the patient is anesthetized and on the table and you can't catheterize the patient, right? So you may have to do reducer dilatation, you may have to do circumcision, which are not told to the patient. So it's always important when you examine the patient, always in male patients see whether the patient has got phimosis or not, right? Or you can try to reduce, right? So if those things are there, and if the surgeon thinks anastomotic healing is threatened, then of course the patient will need defunctioning stoma. That's how you decide, right? So defunctioning stoma, commonly done defunctioning stoma is what in this for these patients? Huh? What is the common defunctioning stoma that we do? Ileostomy. In contrast to colostomy, because colon has been taken down now, and ileostomy is a better stoma than colostomies because of various reasons. One is it's easy to manage by the patient later on, right? Because the effluent is fluid and less smelly, and reversal is also easy. Complications of reversal because small bowel has good blood supply. Therefore, healing is good when you reverse. Right? So, ileostomy is a better stoma for these patients. Any questions? No, I told you the anterior section is removing the rectum. Huh? To defunction. Why? You mean you can take colon also? Oh, colostomy. What is your question? Huh? So we are removing only the rectum. Let's say maybe 2/3 of the rectum we are removing, and we anastomosing sigmoid colon to the rest of the rectum. That's why anterior section. Proximally we take a stoma. Patients are in the wall. So you defunct so that whatever the things will come to the stoma gland rather than going through that and coming through the anastomosis. By defunctioning, creating a defunctioning stoma, you are not going to prevent anastomotic leaks. Anastomosis is going to leak, it will leak, it is going to leak. But the complications of anastomotic leak is going to be less because the stuff won't come. Right? If you do APR, then of course there won't be any anastomosis. Sigmoid colon is taken out, so everything else is removed. Right. And APR patients, remember, you have abdominal wound as well as perineal wound. We have one patient recently in the male ward, right? If you don't see the patient in the male ward, then of course no point teaching these things, right? Okay. Any questions? Yeah, if there is that's a different topic. Now, bowel tumors can cause large bowel obstruction, right? But the rectal cancers very rarely get obstructed. Why? Because rectum is very capacious organ, so it won't cause obstruction. But the commonest site for large bowel obstruction is rectosigmoid junction tumors, right? So in that case, you won't do primary anastomosis. As far as you are concerned, if you say patient has got obstruction and rectosigmoid tumor, then you take, let's say the tumor is here, so you take the tumor out, this segment of bowel, you take out with the tumor, right? And this proximal bowel is massively dilated when there is obstruction, right? So you staple or suture this and leave this part of the rectum in the pelvis and take this part of the bowel as a stoma. Understand? Clear? That operation is called what? Hartmann's operation. So that is for obstruction. Yeah? If the tumor is more proximal, of course, right? Then of course you will decide, because dilated segment is less, then you may decide primary anastomosis. Left colonic obstructed tumors, we take it, do a Hartmann procedure because of two reasons. One is patient may be very unwell. When the patient is unwell, patient may go into SARS and sepsis. I hope you know the definition now. And then patient's blood pressure might drop post-operative period, so the blood supply is going to get compromised to the anastomotic side. Therefore, you make anastomosis. Other thing is, anyway, blood supply to the left colon is not very good. Right? So therefore, anastomosis can cause problems. So you won't take the chance. Right? Once the patient fully recovers, maybe few months later, you can reverse this. Reversal of Hartmann. Okay. Right. Any questions? Now those who are undergoing neoadjuvant treatment, right. Now patients who undergo neoadjuvant treatment, when they come back, we operate after about 10 to 12 weeks. Right? Most of the places in this country operate around 6 weeks. So in the exam, if you take after 6 weeks you give the date for surgery, that's fine. But we wait till a bit later because that's the optimum time, 10 to 12 weeks. But these surgeons who come for your exams might operate the patients after 6 weeks. Okay. Any questions? You should have some question. Right. So can you read around this? Make a proper case history, summary, and keep it. And we will question you now on this in the board. Huh? Have you had class from Mr. Atula about stoma? You know Mr. Atula, the nurse, male nurse, get hold of him and get a class about stoma care and what are the types of stomas, and he will do a good class, right? How to identify what is the stoma, is it diggestion, cholesterol, how to manage, because one of the short cases will be a stoma. Okay.